Thank you for joining us today for the meeting of the New York City Health and Hospital Strategic Planning Committee. Today's meeting is officially called to order. Quorum has been established. I would like to call a motion to adopt the minutes of the Strategic Planning Committee meeting that was held on November 8th, 2021. I would like to ask the members for the votes. Jose?
Yes.
Dr. Allen on behalf of Dr. Katz?
Yes.
Sally?
Yes.
I don't believe Frida is yet in. Okay, thank you. The motion passed. Thank you so much. Now, next, we would like to hear from Mr. Ziegler and Dr. Wei to provide an update on the system dashboard. Matt and Eric?
Hi, great to be with you all. Thanks for having us on this Monday morning. We will start off with some external and regulatory updates from Deb Brown. Deb?
Morning, everyone. Nice to see you all. I'll move pretty quickly. Obviously, most of the news in DC right now is focused on voting rights and filibuster subsequently. We, though, continue to be in touch with our electeds. We are particularly grateful to Majority Leader Schumer, as well as Representative Torres and many other members of our delegation. Some of you have seen, we had a lovely press event outside of Bellevue yesterday afternoon. Their support has helped us get approval for outstanding FEMA funding, which is very meaningful to our system. Otherwise, the executive and frankly Congress continues to focus on COVID-19. There will be both hearings and a speech later this week laying out the Biden administration's, I suppose, position of their activities related to COVID right now. On the regulatory side, we are engaging with the CMS leaders, particularly CMMI, excuse me, on items that are important to us: social determinants of health, health equity, value-based care, and this is work that will continue regardless of the politics that might be going on and other topics. On the state side, you've seen a lot of exciting activity in the last several days. The governor held her state of the state last week. We were very heartened to see so much investment in healthcare, particularly healthcare workforce, a number of other areas that are near and dear to her, dear to us. So we thank her for that very important kickoff. The legislature is in as of today. Legislative committee meetings will start. They are currently still remote, which continues to make life a little challenging, though our woman in Albany, Michelle DeBacco, continues to navigate those complexities quite adeptly. We will see, as of now, the legislature is allowed to function by Zoom until January 15th. So we shall see what happens after that. Next week, we expect the introduction of the state budget. Again, we are hoping it is reflective of so many of the priorities that we have seen discussed and that we have been advocating for both to the executive and to the legislature. And then on the city side, it's also a very exciting time. We have a new mayor, we have a new deputy mayor, we have a new council speaker, we have a new set of council members. And, you know, I think everyone is locked in their unity to continue supporting the city in our response to COVID-19. We are lucky to have a great deal of support from our elected officials, our leaders, you know, the mayor, our boss. You may have seen that we were allocated $111 million in support of our COVID relief work. And so we are optimistic in that regard towards the future, even as we go through another dreadful surge of COVID. Happy to take any questions.
Thank you, Deb. Again, good morning, and thank you for all you're doing. And actually, I was very kind of taken a little bit by the comment about, you know, handling all the legislative session by Zoom and how our person there is trying to manage, because it's difficult to bump into people when you are in Zoom. So
Really hard.
I will be very interested to hearing how she is adapting to that situation.
And kudos to her. You know, she managed it this year, and obviously then, you know, John Olberg and I, Matt, Dr. Katz, whomever, you know, get involved, but she is the person on the ground typically walking the halls and not able to do that. She does an excellent job.
Thank you. Let me just ask each one of the members if they have any questions or any comments. Jose, any questions or comments?
No, just thankful for all the work that I know is happening at every level, as highlighted by Deb, and especially the work with CMS and getting CMS to work with us. And value-based care is particularly interesting. So thank you so much.
Of
Thank you,
course.
Jose. Dr. Katz?
I just want to thank Jose for standing out in the cold and the rain with us yesterday at Bellevue. That was much appreciated. Thank you.
And thank you, Dr. Katz, also, because I know you have been a very strong voice in communicating with our electeds of our about our needs. So that definitely plays a major role. So thank you, and thank you to Senator Schumer, Borough President, the mayor, everybody for making it happen.
If any, one of the nice comments that Richie Torres made is he reminded everyone that he was born at Jacobi Hospital, asthmatic. He sought care at several of the health and hospital facilities in the Bronx, and that's why he's so passionate about supporting us.
Oh, nice.
Awesome. Thank you. That's definitely and having yeah. Patients that really realize the impact that our system has having their lives, literally their lives. I think it's very important and make people understand more at the personal level. So I'm glad that he was able to communicate that and express it. So I just want to, Sally, any comments?
Yes, I have a question. I think the announcement of the FEMA funding has occurred a number of times. You know, we've heard about the Schumer and Richie Torres and the rest of the delegation really working hard on that. But I'm wondering, and we also have like somewhere I read we budgeted like spent $2.5 billion on COVID, and I know that we're getting money from different sources, but I'm wondering how much more real is this $1.1 billion than it was. You know, we had a series of announcements, but I want to know, like, could we put it in the bank?
Is that, I'm sorry, Sally, for me, Dr. Katz?
For whoever has an answer.
I can start with we can put it in the bank when it arrives, and not before then. I mean, the way I see it, Sally, is that the tally of what they owe us grows as we keep submitting more and more sheets, which creates huge cash flow issues for us because the amounts are so big. And that what keeps happening is they send us some money and then it stops. And then the electeds go at them again, get the next trench of money. So each time it has been helpful at getting a trench of money, and the 2.5 represents the cumulative amount, some of which we may not even yet have sent in full information for because it's too recent.
Right. So you think that, I don't know what the process is, what's left for it to actually be a funding commitment. I understand that this continues the focus and the pressure, but did it push us closer to our goal line, I guess is what I'm trying to figure.
Yeah, I think it does. I think the way we send in the receipts, they raise objections, most of which have been unrealistic. Like, we don't want to pay you for for using existing beds. We only want to pay you if you built new beds. And we say that's ridiculous. It wouldn't have made any sense to build new beds. We had empty wards. We opened them. They say, well, we only want to pay you for the positive COVID patients. We say, well, that's ridiculous. We didn't have enough testing in March. We didn't really know who was positive based on testing. We had to make presumptive diagnoses. And so there's a lot of going back and forth and a lot of discretion, and having the Senate Majority Leader call them and say, this is ridiculous. We think you should send the money each time, then results in more money coming. I don't have a sense, though, on what the final, dollar will be, but I'm grateful, for the push.
Absolutely. Absolutely.
Thank you, Sally. I think this is a very good question, but as Dr. Katz said, just articulating the conditions in which the system was working on, sometimes it's difficult for people that were not there on the ground. It's one thing to see paper and read it, another one being there and understanding the conditions. So that's why I was saying that, Dr. Katz and the team being able to communicate very eloquently and aggressively the needs of the system and the work that was done, and then having the delegation amplifying that voice and asking the question, it really shows teamwork and the support and the high regard that the system is held by our elected officials. So I think it's all around. And I really want to again thank everybody and thank Deborah also for your work. You are almost like the glue that keeps everything together at all the different levels. So thank you so much. Is there any other questions? Any other comments? No? Thank you, Deborah. We really appreciate it. And we're looking forward to hear the agenda of our new elected officials in the city. From what we have seen, there is a lot of support from the mayor coming to the system in understanding the effect of Omicron and how the health and hospital is almost at the forefront of combating this and the great job that we have done throughout it. So thank you so much, Deborah.
Absolutely. Of course.
Now it's back to you, Matt.
Great. Thanks again. So we'll go through some of our key dashboard measures, the positive trends, the steady trends, and the few negative trends. The period we're talking about here is the first quarter of the 2022 fiscal year, which is the summer into September of 2021. So just going back in our memories, this is pre-Omicron. There was the rise of the Delta variant, but overall, I'd say a quarter of, pretty close to new normal operations, if there is such a thing. And you see some of those results here. So some of the key positive trends are hemoglobin A1C control, a measure of how well we're doing helping our patients control their diabetes, did creep back up again. You'll remember this had fallen several quarters in large part because of us having to scale back in-person ambulatory care. But in this period, we had returned to it. Of course, again, now because of Omicron, we have scaled in-person ambulatory care. So we'll have to work doubly hard to get this back up in future months. One of Kim Mendez in the IT department's critical activities integrating biomedical devices into our electronic health record system, beating its target ahead of the trajectory there, which is excellent. 1,383 devices integrated in the quarter. That's a good trend. Next slide. Our MyChart patient portal activations continue to increase. We're heading towards that 75% target, which again is so far above the customer average of Epic across the whole country of 47%. So we're thrilled about that. NYC care enrollment is very close to that 100,000 target. So continuing to make great progress there on healthcare access for our neighbors who are unable to afford or ineligible for subsidized health insurance. Next slide, please. On fiscal sustainability, very proud of the team, the frontline financial counselors, registration staff, and others who have helped the percentage of our uninsured patients who are either getting enrolled in coverage or getting financial assistance, NYC Care, chiefly among them. That is up to 90%. The target was 76%. It's been less than a year since we rolled out this new target, so we'll look to update it as we see if we can sustain this 90%, but a great accomplishment helping more New Yorkers get access to coverage and financial assistance and make sure people don't get bills inappropriately for services that they can't afford. The percent of Metro Plus patients receiving their care and that spending happening at health and hospitals has peaked above 40%. This is a big number. Every move here is millions and millions of dollars of new resources for our system. So great to see some progress there. Our accounts receivable days dipping back under 60 days, which is excellent, but still well above that target. So we'll keep pushing hard on that. And the other big information technology project that we track here is the data center migration project. So it's at 17% of the total project completion, and the milestones for this quarter are at 100%. So they are on schedule there and heading towards completing that big project on time in May of 2023. Next slide. On our access to care, the number of e-consults, again, this is our specialty care electronic referral and processing system, has remained stable around 100,000, still above the target. And the work there continues to be finding key new specialties to build out expected practices with, and standardize e-consult as the primary way we do initial specialty consults around the system. So that work will continue, and I expect it starts to rise in big jumps as we roll it out for a new specialty across multiple facilities around the system. The financial sustainability metrics remain pretty strong, 74% of our patient care revenue over expenses. We will revisit this target next quarter because after years in the 50% range, we have exceeded our expectations on billing, business plans, managed care rates, and other things, and getting ourselves higher up here. So we have to set a new bar because we've had great success, which is excellent. And on post-acute accounts receivable days, relatively stable and still beating the target. I see Eric is on. So Eric, if you want to talk about culture of safety and any of the other metrics in your area coming up.
Sure, thanks, Matt. So our total H3 wellness encounters, I would say this is consistent, 641 compared to 688. And so we see this dip a little bit during kind of low COVID case periods, and then it goes back up during each wave. So I expect this next period to show more, but we're calling this pretty steady at 640. Next. So our quality and outcomes post-acute care all-cause hospitalization rate also stayed steady, 1.73 per 1,000 care days to 1.71. This is still a little short of our target of 1.0, but I know Coy and team are working very hard on this. Next. The left without being seen from the emergency department. This is still right at the target of 4%, which I think I say every quarter is really good for the trauma centers and being in a safety net system. But it has come up a little bit as our census in the ED has returned to closer to normal. I think during this wave we'll also see this bump up, but hopefully we can get it back down under 4. So some of our negative trends, just a reminder, we did switch the behavioral health discharge appointment kept within 30 days to Epic as our data source, and so that saw a big drop in it. But we also did see a 7% drop from 44.7 last quarter to 37.07%. We revised the target to 50%. I think some of this is also volume related. So we saw during this pandemic a much increased demand across all age groups for behavioral health services, and so trying to do performance improvement on this as the volume has grown, has led to some of this drop. But there are many things that Omar Fatal and Charles Barron have in the works, including telehealth, and adding behavioral health into virtual express care, and leveraging that to be able to meet this 30-day QI metric here.
Self-metric.
For access to care, our unique primary care patients dropped about 2,000, still below target of 405,000. And so I think this is probably common cause variation. 2,000 out of 400 is a pretty small percentage. For care experience, our inpatient overall top box rating dropped a little bit from 66.96% to 64.5%. The target is 66.3, so we went from above target to dropping below it. So this is one that we're tracking very closely. Our Plane Tree patient-centered certification initiative is addressing this as well. I think our big boost during the early 2020 pandemic, we're seeing that kind of come back down towards the mean a little bit, but multiple initiatives, Plane Tree, eye rounding, and other things to drive this back up. Ambulatory care also dropped a couple percentage points from 86.99 to 84.6. Next. Okay. So these are our new racial and social equity measures. So very happy and proud of Dr. Nicola Davis and the population health team under Ted Long to get our 5 chronic disease dashboards to 100%. Remember last time it was 2 out of 5, so now 5 out of 5 of these population health dashboards can be stratified by race, ethnicity, language, and that was our target, 100%. And so working with the Equity and Access Council and Nicola's leadership of now what do we do with the data to be able to do targeted performance improvement around any disparities that are found. Our MWBE total procurement spend just below target, 28%. I know Danielle Dabari and team are working very hard to get this number above the 30% benchmark there. And this is the first time we're showing this third equity metric. So we had identified that we want to see the percentage of new physician hires coming from underrepresented minorities in medicine. And so this is data that comes with a big caveat. So similar to our patient data, when we looked at real SOGI data, there was a significant chunk that was in that unknown group. And so the same thing this here, data that we're getting from our affiliates, 66.4% are unknown. And so this is only 33.6% of the new hires in this period. But still, we thought interesting to look at those. Can we go back, please? So of those that we do have data on, 45% identify as female, 0.3% non-binary. Of the ethnic groups hired other than white, Asian made up 11.4%, Black or African American made up 6.4%, and Hispanic or Latino made up 1.9%. And so I know we're working very closely with our affiliates, just like we are with our patient epic data, to try to reduce that unknown down as close to 0 as possible. But still, I think interesting to see this data, even though it's incomplete, and we'll work to make sure that we get it closer to a complete data set. Any questions so far?
I have.
Go ahead, Sally. Go ahead, Sally.
I don't know if it's appropriate at this point. I had 2 questions about points that were made earlier. Should I wait to the end, Penny?
No, Sally, I think this is a good time. Eric has
Okay.
asked for questions, so Sally, and I will then ask all the other members if they have any questions. Thank you. Go ahead, Sally.
Okay. One, I like the new format very much, highlighting certain key points and then footnoting the supporting documentation. I found that extremely useful. Two, I had questions about, or I guess this is my first question then, a question about the New York Cares funding. I'm glad that we're at 90% of insured patients now, but we renewed the New York Cares funding a number of times. How much longer do we have funding, or have we gone back for additional funding?
Thanks, Sally. No, we have not had to go back for a different or subsequent request. It's been a guarantee from OMB for the past several years, and
Right.
I think we have ongoing discussions with them about how much of the 100 million or more a year that will be needed for the program they need to allocate as part of our ongoing subsidy from the city.
Okay.
So I think we'll have those routine discussions with them going into the January plan. And perhaps in the finance committee meeting next or at a subsequent meeting, we can talk about where we are in spending that and how it's going against that projected budget that we put together.
Okay, that would be great. And my last is just a point that I think I made earlier, but I think it would be wonderful once or twice a year to have the strategic planning committee report to the board as a whole, because the whole issue of corporation strategy is really a board responsibility. And I know we include the minutes with our board materials, but I don't think that's the same as really saying, we have clear strategic directions. These numbers all reflect a strategic direction that we're taking, a priority that we have for the organization. So I think it would be, and maybe Coalicia would know better, but I think it is important to talk. It's the numbers, of course, but it's also the principles and priorities that are embodied in the numbers.
Well, thanks for that opportunity, Sally. We'd love to do that. I think the points in the year, just to talk it out with the group, and we can work through this offline. As we finalize the system budget for the year in July, that's a sort of another statement of strategy and principles and priorities. And John and I tend to try to talk about the strategy behind that as we report it out to the board. So that could be an opportunity to bring those two together and report to the board on where we are in our overall strategy and how it fits into the budgets. But there are ample opportunity, happy to do it whenever and in whatever form the board would like.
Yeah, it might be sooner because the budget discussion is so consuming. I'd really like this to get focused on.
Sure, okay.
I think, Sally, that's a great suggestion, and I think we will have to work with Coalicia on the timing and the agenda for the board meetings, but Coalicia, she may be able to share with us later in another time what she thinks about it. Yeah.
Okay, thank you.
Any other questions, Sally?
No, that was it. Thank you.
Thank you. Jose, any questions to Matt and Eric?
No questions, just great work, and I'm glad to see that not only are we meeting clinical goals that are relevant to us, connected to quality, to equity, but also hitting financial targets on the revenue side. Thanks.
Thank you, Jose. Dr. Katz?
No questions, thank you.
Thank you. I just have a comment. I just want to again praise Eric and Matt because we have seen how the strategic plan have been kind of implemented, embedded into every aspect of the organization and taking into consideration both the feedback that comes from the organization to fine tune it and improve it every time that we see it. And particularly, I would like to give kudos for the racial and social equity measures. That was feedback that came to the group, and Eric and Matt took it to heart and really made it happen. And if you recall, last time these metrics about the number of dashboard that had race, ethnicity, and language data was 0 out of 5, but now we have all 5 completed. And we saw in the Committee for Diversity, Equity, and Inclusion, very interesting data that is coming out of those dashboards. So I just want to thank you. And also looking at how we are monitoring now our new hires and be able to now track our performance. I think this will allow us to really see where we have to maybe spend more focus in a particular area in attracting and communicating what a great place health and hospital is to work. I just want to say thank you, both of you, of course, the larger group at Health and Hospital, for the amazing work that you are doing. And of course, I have to echo what Jose said, all within a very financially sustainable framework, and I think Dr. Cass has to take a lot of the credit for that, for kind of leading and communicating the importance to have that very strong financial foundation. So thank you so much.
Annie, this is Michelle. I just have
Yes.
one comment to make.
Yes, Dr.
Actually, two, I want to repeat the tremendous progress that has been made with the equity measures that we're finally able to track by racial and ethnic group or outcomes. And unfortunately, African Americans are the worst performing when you look at the outcomes. But I do want to share that in terms of the percentage of our staff and our patients who select other as their racial and ethnic group, just a word of caution internally, I don't know how much progress we can make on that. Having had these conversations with friends of the family who check other, there's real dissatisfaction with how the US Census Bureau and others have defined race. So I think until the definitions are addressed, and it's not by us, it's by our external partners, we will always have a significant group that classifies themselves as others, especially in a city like New York, where there is a lot of mixing behind racial identities, so that specifically my son's children will probably neither identify as African American or white. And those are the only two racial groups. They will probably identify. It's a generational thing. I think we're not as segregated as we once were. Need to be realistic on our expectations of lowering the percentage of others. Not that we shouldn't try and get people to identify themselves accurately, but I think there will be only so much we can do internally, Eric.
Yeah. No, great point, Michelle. And I think for us to tell the difference or see if there are ones in the unknown where we truly just don't have the data versus the other. And I agree with you 100% about, right?
Yeah. Great work.
Yeah. And thank you, Fanny, for the kind words. But Matt and I are just messengers here, and it's Hillary and the entire team, Alex, who are getting us this data. But it's Mitch's vision, it's Mitch's leadership team, the strategic planning group, and everyone else across health and hospitals that are doing the amazing work. We're just the ones that are sharing the message. So, but I appreciate the kind words.
Thank you, Eric. As always, very modest. But as you say, it takes leadership to communicate values and to ensure that people understand those values and work toward achieving and living up to those values. And I think all of you really do an amazing job in doing that, and the system has responded accordingly. And so thank you, and your modesty is always noted. I just want to follow up in Dr. Allen's comment, because I do understand the challenge with the classification. Classifications are always very, very difficult for some people, particularly if it is not as clear cut as one will wish. But maybe, and that's something that maybe Eric, Matt, and your team can look at. We do have to report this data to the federal government or the state government in certain fashion. But I don't know if that precludes us to be a little bit more granular in providing other options to individuals, even though that is not reported. So we may want to maybe there are ways to find out how people are feeling about these characteristics, categories, and how we can do to get a better grasp on those. Because as you know, as Dr. Allen says, we have here of this data, 66.4%. We don't have information, it's unknown. Maybe because data is not available, but also we don't know if it is because people didn't want to fill it out. So I think that's maybe, but it's good that we are at this point. At least now we are trying to track it. Now we are trying to curate the data to ensure that it captures as many people as possible. But thank you, Dr. Allen, for bringing that to the attention to all of us. It's a very important point.
And we have some good lessons learned from the patient side too, right? Epic initially for ethnicity just had Hispanic and non-Hispanic. And so through Matilde Roman and Equity and Access Council subgroup, they've now expanded it. I forgot how many, I think 30 different options or more. So there are certain lessons learned from trying to get the real SOGI data on the patient side. And we should apply those same lessons to our staff.
Very good point. I think definitely learning from any other work that we have done, that we have seen and gotten feedback, I think that would be very helpful. Very, very good point. Thank you, Eric. So,
I think the next slide is our COVID data. And so this is coming out of wave 2. Coming out of, so wave 2 was last January through March-ish. So this was kind of a relatively low period for us. You see it's about the same as the prior quarter, 746 tests administered versus 884. Positive tests, a little bit lower than April through June at 21,500. Our post-acute COVID infection rate, 7.93 compared to 7.37. And the vaccine doses slightly up from quarter 4 21, 510,000 first doses, 425 second doses, and our bed occupancy was lower than the April through June period. And so right below the chart, you'll see that boosters became available during this period. And so for August through October, 17,940 third doses or boosters were administered.
thank
So
you.
this does not capture Omicron at all, as Matt mentioned.
Okay. Thank you, Eric. I just want to see if there is any questions about this particular data. Again, it doesn't capture the Omicron kind of way, but Jose, any comments or questions?
No, thank you.
Dr. Katz?
No questions. Thank you, Fenny.
Thank you. Sally?
No, Fanny, thank you.
Thank you. And thank you, Eric and Matt, for sharing that issue of the booster, because you know, once you start reading the newspaper and all that, a lot of places are looking at kind of the redefinition of what is fully vaccinated to include the booster, and a lot of different organizations are requiring the booster. So I think that it's good to capture that data, and I believe that next quarter we're going to see an increase on significant increase on this particular metric. So thank you for capturing. So again, back to you.
Great. And so the last two slides here are just our glossary and then the full dashboard. Again, our motto here is red is our friend. It teaches us where to focus and where we need to redouble our efforts. So some key areas of focus, but overall, I'd say a lot of progress on our 5 strategic pillars and our foundational issues of racial and social equity. So thank you all again for the time, and happy to take a broader strategic discussion up at the full board meeting, and welcome anybody's further feedback or questions. And thanks again.
Thank you, Matt. Jose, any overall questions or comments?
No, thank you.
Dr. Katz, any overall questions or comments?
No, thank you.
Sally?
No, thank you.
I just have a kind of overall questions, Matt. When we were talking about the number of the kind of these 2 red that we have here in the care experience, is there anything in particularly that we have to pay close attention? Because here we have 3 measures and 2 of them are like in the red, and this is a very important area for us. Is there anything that we should be looking at or paying closer attention? Are they having any discussions?
Yeah, I'll turn to Eric. I think his team is very close. There's no silver bullet on this one. I will just say, we had an entire group of, I think, really every VP and senior VP in the system last week talking to Press Ganey, who is our vendor that tracks this and advises us and tracks the surveys. So the leadership level of attention on it is critical. From my perspective, I'm a little biased, but part of the key here is access to care, right? I always think that easy access, good customer service can certainly increase that ambulatory measure a lot. But I think there's, a multiplicity of factors here. Eric, any particular ones that you think coming out of that Press Ganey call or other venues you think we should be focusing on?
I mean, in the Press Ganey report, which I really like because there's so many different metrics, they do something called key drivers, right? You can't focus on all of them all at once, but they will do the data analytics and boil it down and say, right, these are the 3 key drivers in the emergency department, ambulatory, inpatient. And so it's really incorporating that into our balanced scorecards as our teams select what are the SMART goals that we're going to create for our 5 PI projects in each unit and department, and they're aligned with the 5 strategic pillars. So one of those is care experience. I do think some of this is right. That whole thing about focusing on your employees so your employees can focus on the customers and the business will take care of itself. Really doubling down on the wellness of our staff coming out of this pandemic. Like it's been going on for almost 2 years now, and people are really tired and really drained. And so the more that we can do to have our staff, refill their tanks and heal, they'll have more to give to the patients, right? And answer the phone with a happier demeanor and right, have more to give, right? And so that is where a lot of our effort is right, making sure that our staff are processing, even though the pandemic isn't over, so that they have more to give. And I think it is challenging to, right, and Mitch has mentioned this multiple times, he hates seeing his patients through telemedicine. You can't develop that same rapport. You can't put your hand on their arm or their shoulder, give them a hug if they're going through a hard time, right? You just can't recreate that through WebEx. And so I think some of it is when we do get back in person, that human-to-human interaction will be better.
Thank you both, Eric and Matt. I think this is very important. I think this issue of, if you want to call it broad mental wellness within this particular situation, because everybody kind of get ready when something happens that is bad and put all the energy 150%, but usually it's burst. Now we're talking about a long period. It gets really to people and affects their family, the relationship with family, because every day they are seeing all that and these waves. And I know that in the past we had some discussions about the residents and some of the suicides that we have seen in our resident groups. So maybe, again, this is something that Coalition may want to look, and Dr. Katz, if there is maybe a way for us to have a conversation how we are dealing with this and supporting our staff, so that they do feel that the system is there for them and that we do understand what they're going through, and we appreciate. I know that there should be a lot of activities going on in the different hospitals and in the different facilities, but maybe having just a focused conversation on this, and I think that will allow us to see more holistically what we're doing to support our staff. But again, I will leave it to Coalition, Dr. Katz, if they feel that that would be valuable to have a discussion either at the next strategic planning committee or at the broad level, as Sally has mentioned, in terms of the strategy and how we are operating. But that will be up to Dr. Katz and Coalition. And Jose, sorry, Jose, you are a key decision maker on that one as well. So that was all.
I
Yes.
am hopeful that things will be better in February, and that I think board members coming out to the hospitals and the clinics is always incredibly appreciated by the staff. People really, and maybe it's analogous to the challenges of doing primary care through WebEx.
Exactly.
What people really want is to see you, right? They really want you to walk through the hospitals, to be together. And of course, that's really hard for us to do right now. But I'm hopeful that Omicron will peak in January and that by February we'll be in a more normal place and begin to, resume the human interactions that's what people are craving. They're craving human interactions. They're craving being with their families. They're craving traveling. They're craving not wearing, N95 masks, which are incredibly uncomfortable. They want to, go back to human interactions.
Yeah, I will agree, Dr. Katz. And I know Sally is our leader on that issue of visiting our facilities. I know that she sent several emails. We were already planning some visits, but then Omicron came in and I think put a hold on that. But I know that Sally will be looking at the next opportunity that we can go back there. We really enjoy. I think it was a really great way to know about the facilities, what they are doing, and the great work that they are the patients. I know that when we visit Wood Hall and visit the residential facility that they have, was really touching to me to see how those patients were being able to be supported and how grateful they were for what the system was doing, as well as the city by providing them housing and allowing them to live like fuller lives. So Sally, you have your task for 2022 to get us back out there.
I'm on it.
Okay. Again, thank you, Dr. Katz. Thank you, Eric and Matt. And I don't know if Deborah is still here, but thanks also to her. I think there is no more material, Eric, that you or Matt, that you want to share.
No, sir.
No. Is there any old business that we should discuss for the strategic planning? No. New business? I think hearing none, I would like to adjourn this meeting. Again, give you 10 minutes. So today I have given you 40 minutes. So I will catch in on those. Thank you so much. See you the next meeting.
Thank you.
Bye. See you. Bye-bye.
Thank you.
Bye.
Bye. Bye.
Bye. Thank you.